This is not a problem for the surgeon?
We don't want to go in and the stomach is full of food.
The next episode of Endoscopy Essentials. My very special and dear guest is Mouen Khashab from Baltimore. Welcome, Mouen.
Thank you, Thomas, for having me.
So we are doing some deep diving into therapeutic EUS, which started with cyst drainage and rather simple things, but one of the most successful procedures recently has turned out to be endosonographic gastroenterostomy, right?
Yes.
So when we approach the patient, the first thing is about indications. A patient with gastric outlet obstruction due to malignancy, I think. That's what we are limited to, right? So benign conditions, indications are starting to evolve. Do you do benign strictures?
I would say the primary indication is malignant gastric outlet obstruction, whether it is resectable patient and also unresectable patients. There are some indications for benign disease. I would say that these account right now for about 5% of cases. So the vast majority is malignant gastric outlet obstruction. And there is a specific entity of benign gastric outlet obstruction where gastroenterostomy plays a role, and of course we can discuss that.
Okay, you said resectable disease. So when you make a connection between the stomach and the small bowel, this is not a problem for the surgeons?
Yeah. So obviously the surgeon is going to form a new gastroenterostomy. Our gastroenterostomy is a little bit more proximal in the stomach, so it usually doesn't affect them. Imagine a patient has had previously a biliruth 2 or a laparoscopic gastrojejunostomy, and subsequently they can have Whipple procedure. That usually doesn't get in the way. So it doesn't really alter the surgical procedure. And these things, we always discuss them with our surgeons to see what bothers them and what doesn't. This is one of those things that doesn't really get in the way.
Okay. Anything else, like, many of those pancreatic cancer patients, for example, they have ascites?
Yeah. So in patients who have severe ascites, usually it is due to carcinomatosis. These patients' survival typically is less than 3 months. The advantage of a gastroenterostomy as compared to a duodenal stent is decreased recurrent gastric outlet obstruction. In these patients with short survival, you're not going to see this advantage. So in these patients, we just place a duodenal stent.
Oh, I see. Okay.
In a patient that happens, they still have good functional status, and it happens that they have ascites. If the ascites is drainable, I think it's okay to do gastroenterostomy, or if the ascites is loculated, it's not in the way. But in patients with massive ascites, where the jejunum is basically bathing in fluid, the procedure should be contraindicated because there is increased incidence, of course, of infection, but also of dehiscence. Since this anastomosis is not going to happen, the stomach is not going to adhere to the small bowel because there's always fluid in between. So in these patients, we will say it is contraindicated.
Okay, so there is an individual limit. Which do you need a CT beforehand? I mean, most of these patients have a CT anyway, right? Which is rather recent.
Yeah. So the majority they have. Usually these are inpatients, and they come with nausea, vomiting, and not tolerating oral intake. So uniformly, we will have a CAT scan or an MRI in these patients, because it's also important to exclude a more distal obstruction as well. So imaging is a must, and it's usually they have maybe multiple imaging procedures.
Right. I think that's also very important what you mentioned, that this should be the main obstruction. And if you open up this one and then 50, 60 centimeters below there's another obstruction, it doesn't make sense.
Yeah, then you've exposed the patient to a procedure with possible adverse events, but without any benefit. So typically most patients will have one level obstruction, but carcinomatosis can result in small bowel obstruction and twisting of small bowel more distally. So in these patients with advanced disease, it's a must to rule out a more distal obstruction.
Okay. Good. Then you would look for some other way of drainage or PEG or something to
Yeah, and
the symptoms.
these patients usually they get a palliative venting tube or an NG, or it's difficult because even a PEG can be very difficult in these patients because of the ascites and the carcinomatosis.
So there's a limit to everything naturally.
Exactly.
Yeah. So anything else we forgot as preparatory steps before you start the procedure?
Yeah, so we typically like the patients to be, typically patients are not tolerating oral diet. If somebody is tolerating some kind of diet, we like them to be MPO or just purely on liquids because we don't want to go in and the stomach is full of food. We actually like to place a nasogastric tube for more than one reason. First reason is to avoid aspiration during the procedure. I mean, this is extremely important because we've seen it. So it's very important to decompress the stomach before we go, and also to basically to prepare the patient for a procedure. If the stomach is full of food, gastroenterostomy is impossible. Duodenal stent is still possible in these patients. So I'll say this is one of the advantages of duodenal stenting. If you go in and the stomach is full of food, you know, this is when we say we're gonna put a duodenal stent.
Oh, I see. At the end, it's not mutually exclusive. So at a later stage, you still could do it if in individual cases.
Correct.
This brings me to the next issue, sedation. Is general anesthesia desirable or necessary?
Yeah, so this is a little different between Europe and the US. In the US, uniformly, these patients are intubated. I mean, in the US, even if we're putting a PEG or a duodenal stent or a GJ, any patient who has gastric outlet obstruction gets intubated because of the increased risk of aspiration. In Europe, there is, I think, problem with sometimes with availability of anesthesia. So these patients get an NG tube, decompress, and then followed by maybe endoscopy the next day.
Well, we do it under general anesthesia in an increasing number of centers in Europe as well. So I think it might be changing because it's safety first at the end of the day.
I agree.
And if something happens, it's always difficult to explain, well, for organizational reasons and this and that.
Yeah, and these patients are sick. So having a massive aspiration episode, you're trying to help them, and suddenly they have now a pneumonia. I don't think that's a desire. I mean, we should try to avoid that for sure.
Okay, but also sometimes anesthesiologists may place a nasogastric tube before, you know, to have a safer intubation. So, but that's their responsibility then.
Yeah, although decompression takes some time. With high residual food, like a lot of food in the stomach, it takes a while to decompress it. So just placing an NG in the pre-op area can be problematic. And these things we've seen. We kind of developed this algorithm that this is a must because some patients have some symptoms, you know, mild symptoms, just unable to eat a full meal. They're not really vomiting. So when they get admitted, the teams on the floors, they're not placing nasogastric tubes. So we ask them now to place a nasogastric tube the day before. Okay,
so let's assume we have optimal conditions. The patient is taken care of by the anesthesiologist. Do you usually do a probatory EUS to see where the small bowel is, or is a failure due to anatomic conditions after looking at the CT, patient seems to be suitable, is a failure so unlikely that you just go in for the procedure?
Yeah, you go in. Yeah. It's hard to determine that by CAT scan. There is a small subset of patients where the small bowel is all on the right side of the patient. Just an anatomic variant. These patients, I mean, you're not going to be able to do a gastroenterostomy. That's the exception rather than the rule. And, you know, if the CT also is important, if the mass is around the ligament of Treitz, because our target loop is usually either D4 or proximal jejunum. So if the mass is there, procedure is expected to be difficult. Some anatomic variation where the small bowel beyond the ligament of Treitz kind of makes a loop up towards the stomach, then it becomes possible. But if the obstruction is relatively distal, expect a more difficult EUS-GJ.
Okay, and so when the patient is intubated, you go in with which scope? A gastroscope or a small, thin colonoscope?
I typically go in with a therapeutic upper scope. Because, you know, before EUS, you have to fill the small bowel or insert a nasojejunal catheter.
Or empty the stomach.
Or empty the stomach. So I like the therapeutic, and then I like to, you know, the therapeutic scope allows you to put the nasocystic or the nasojejunal catheter easily in the small bowel. And there are various techniques, and we will talk about them in a little bit. But the therapeutic scope has some advantages. Just better suction, catheter placement easier. And you have to fill the small bowel to determine is EUS-GJ possible or not. You cannot go in and look at the small bowel before filling it. So it's typically you fill and then you examine with EUS.
But it's not necessary to pass the stricture, so therefore take a pediatric gastroscope or so. You do it under X-ray.
Yeah, of course. Most patients...
Always.
Yes. Most patients you can't pass the stricture. That's why they are symptomatic. So you have to basically fill the small bowel under X-ray from proximally, either injection through the scope proximal to the stricture or placement of a nasojejunal catheter across the stricture. But that's all done under X-ray.
So you already mentioned there are several techniques of filling the small bowel. So please tell us which you are using and how that looks like.
Yes. So and this is my individual approach to this problem, and I made an animation video to illustrate the techniques. So this is here a gastroscope in the stomach, and we just place the gastroscope proximal to the side of obstruction. So I align the channel of the scope with the lumen, and I inject fluid
through the
contrast through the scope. If it fills the small bowel, then I don't need a nasojejunal catheter. I go in with EUS and perform a gastroenterostomy. If I can't align it and most of the fluid is coming back into the stomach, then this technique I just mentioned becomes ineffective. So this is when we place a I like to place a nasocystic catheter, and because these have a loop and it's easy to advance to the small bowel, we usually advance it to around the ligament of Treitz. So, and then we pull the gastroscope out, leave the nasocystic catheter or nasojejunal catheter in place, advance the EUS scope, and start injecting fluid through the nasojejunal catheter.
But wouldn't it be advisable to do this nasocystic thing anyway? Because maybe you have to inject later, the fluid goes down, and then you have air, etc. So is the first technique you are showing, you have to be very quick then, right?
Yes. So, and you know, again, this is my own approach, and some people disagree with that because some people go straight to the nasojejunal catheter. So there are pros and cons for each one. So the advantage of injecting through the scope, I would say in 8 out of 10 patients, I'm able to inject through the scope. You can align it well. The advantage of that is when you're pushing with a 60cc syringe under pressure with a force. So that pushes the air away from the small bowel, and that is a distension force. So the small bowel, you're distending it. You're putting tension on the wall. You see the small bowel more distended. More importantly, when you do the gastroenterostomy, there is less stenting when you push in the lumen opposing metal stent. The issue with tenting, because the wall, although the small bowel is filled with contrast, it kind of bows like this. If it's under tension, it's not gonna bow. Then it is safer. Injecting under pressure has this advantage. But the disadvantage is you have to be quick. Of course, we give, in the US, we give glucagon.
Yes.
And I give 3 milligrams. And here you give Buscopan.
Yeah.
And both work okay, but they are short-acting. So we give it every 3 to 4 minutes. The whole procedure takes 10 to 12 minutes, so it's pretty quick. But our gastroscope and the EUS scope are already attached and they are ready. So we just switch the suction and then we place the gastroenterostomy. So it has to be quick. If for some reason you can't fill the small bowels this way, or you go in and you're losing, there is exaggerated motility. Some patients for some reason have exaggerated motility, you can't slow it down, then you go for the backup technique and put a nasojejunal catheter. Some experts, especially here in Europe, use the nasojejunal catheter for all cases. For me, contrast trickles through the slow. It's a slow trickling. You fill the small bowel, but
It takes a bit longer. And
It doesn't take actually that long, but you see exaggerated tenting. But I think both of these techniques are gonna become practiced less and less because, as you know, there is a double lumen balloon, a double balloon catheter that is going to be available soon. And I'm happy to show you a video that illustrates that. I'm gonna play so there are three techniques we said: through the scope, nasojejunal catheter, and the double balloon. Why don't we show a video of each?
Yes.
Okay.
Great.
This is the first technique where we inject through the scope. This is a CAT scan showing a massively dilated stomach. And this is a very proximal gastric outlet obstruction due actually to a duodenal hematoma. This is a gastroscope. You see there proximal to the obstruction. And you see how the contrast is all going forward. Nothing is coming back to the stomach. So we inject 300, 400 cc's, and then you go in and you see this beautifully dilated jejunum. We aspirate fluid to ensure it is blue dye, so we know this is a jejunum and not the colon.
So blue dye is added to the contrast?
Yes. So usually the fluid is combination of contrast, dye, and methylene blue. And the needle is a finder needle, and you see that you're aspirating blue dye, so you know this is the small bowel. So this needle, the finder needle technique, is important with this injection through the scope. If you're injecting through the nasocystic catheter or nasojejunal catheter, you don't need that because you see the bubbling of fluid while injecting live, and also you see the catheter itself. So let's talk about this nasojejunal catheter. So now you see the catheter there that's looped around the ligament of Treitz, and the EUS scope is down, and this is when you start filling the small bowel. So you're there, you're filling it in front of your eyes, so you don't need to find a needle. And you're giving glucagon, and then you see a dilated small bowel, and you go freehand also and do a gastroenterostomy. So you see some tenting there. Did you see that?
Yes.
So some tenting.
Yeah.
But if you have a good experience with lambs, you know, it works out okay. I just noticed this, and I take that seriously with the tenting technique. So this is the nasojejunal catheter technique, and by the way, for the proximal flange, we're always deploying it inside the scope. So intra-channel deployment, and then we just push it out. I think that has become the standard of care. So most recently, we have this double balloon catheter that shout out to Dr. Yenny Shen from McGill, who was our fellow at our hospital, and he had really good experience with EUS-GJ during training, but he saw that it's difficult. So he thought about, you know, an idea, and he developed a company and a device. And this was recently acquired by a large company, and so hopefully that will result in availability in the market soon.
And you think it improves safety?
Yes, and I'll show you why. Because so the advantage of this catheter is that it is through the scope. So you push it through. You have a therapeutic scope. You push it through the scope, and you pull the scope out. So the catheter stays in. The older double balloon catheter was not through the scope. And you know, when you go over a wire in a J-shaped stomach, it loops. So you need, frequently you'll need an overtube. With this catheter, you don't need an overtube because it's going through the scope. And so let's see it. It's called NAGI catheter, and it goes through a therapeutic upper scope. And you'll see here, this is the catheter, and the scope is being pulled out, and the catheter stays in. So the innovative aspect of this catheter is that the hub, it's detachable and attachable. So that's why it can go through the scope. So now you're attaching the hub, and it's multi-lumen. So of course, one of them is over the wire, and you have one for each balloon. And each balloon gets about 40 to 50 cc's of air. And basically you're trapping the small bowel in between. Now you go through the channel and inject dye between the two balloons. So now you're distending a specific target around the ligament of Treitz. The small bowel loop is not moving because it's fixed with the two balloons, And also the distension is under pressure. Like now the small bowel is under pressure, so you see almost no tenting, because and this phenomenon is really important, the tenting. So now you're filling it, and your EUS scope is there. So you're seeing the loop. This is around the ligament of Treitz, and you see a very nice dilated and stable loop. This is not going anywhere, where the wall is under tension.
So it combines the advantages of both the prior techniques.
Yeah, I think so. You know, there is an extra step, of course. You're putting the catheter, but the procedure should be short and stable, and I think it's more scalable this way, because now very few people are doing EUS-GJ. So even if the procedure has a lot of advantages, if it's not scalable, you're not really serving patients. If you make the procedure safer, easier, then we will be able to serve more patients using this technique. I think once this is available, there is no reason to use any other technique.
Not to use this. Okay,
Yeah.
perfect. So this is part 1, and we like to end with a cliffhanger, so please come back next week for the next episode.